Good evening. Yes.
Please continue. Sorry.
Sorry, sir. Good evening, respected Professor Sir, and my dear students. I welcome you all for this next session of TNB online academic activities. Today we have the continuation of the previous session on respiratory physiology, followed by applied respiratory anatomy. Over to Professor Sir. Thank you, sir.
So we saw some of the physiology related discussions in the last class, and for a change now we will start with the anatomy topics pertaining to respiratory system, and then go back to some of the physiology questions to make it a little more interesting. So, are you able to see the slides?
Yes, sir.
Okay. So we are going to start with the anatomy of the nose. Nose is also an important portal of entry for the respiratory system, and quite often questions come up in the theory examination with regard to the anatomy concerning nose. And as practicing anesthesiologists, we need to have some important practical applications of the anatomy of the nose, which we will be dealing with now. So the first question, what are the bones which form the framework of the nose? You can just mention the names of the bones alone.
Nasal process of frontal bone, sir.
Nasal process of frontal bone, okay. And
Ethmoid bone.
Ethmoid bone, sir.
Ethmoid bone, very good. So there are almost 6 to 7
Maxilla.
bones.
Maxilla.
So the
Pterygoid plate.
ethmoid bone, frontal bone, lacrimal bone, nasal bones of the front, again the frontal process, palatine bones and sphenoid. All these things form the bony work for the nasal cavity. So totally there are 6 bones you have to remember: ethmoid, frontal, lacrimal, nasal of course can be part of frontal also, palatine and sphenoid bone. Okay. Which cartilages contribute to the nasal septum? Because nasal septum is made mostly of cartilages, whereas the nose is made up of
Both
septal cartilages.
Yes,
Why we have to know about the nasal septum, and what is the importance of this cartilages which are contributing to the formation of nasal septum? When you want to do a nasal intubation,
yes, sir.
what is the examination you have to conduct the nose?
We have to look for the septum, whether it is straight or deviated, sir.
That's a very, very common anatomical abnormality, deviation of the septum to one side, much
Yes,
more
sir.
prominently than the. So there may be a roomy area on one side and a narrow area on the other side. So unless you make out that deviation and select a larger nostril, you may be traumatizing the septal bone, septal cartilages, because more bleeding. So this knowledge is very important. And also there is a surgery related to septum. What is the surgery normally done if it is a deviated nasal septum?
Septoplasty.
Septoplasty, very good. It can be called septoplasty. Earlier it used to be called submucal reposition of the nasal septum. SMR, they used to call it as SMR, submucous reposition of the nasal septum. But nowadays it is called septoplasty. So septoplasty can be done for what purpose? What are the indications for doing the septoplasty?
Sir, chronic obstruction.
Yeah, patients may complain of chronic obstruction on one side, inability to breathe in the night, especially when the mucous layer gets swollen because of congestion. They find it very difficult to breathe through one nostril, and they keep breathing only through the larger area. This may give rise to chronic infection in the adjoining sinuses close to the nasal cavity and lead to a chronic sinusitis-like picture. So that may require a correction. Any other reason for doing the septoplasty? Even if the
Cosmetic
patient
correction, sir.
yes, some of the olden days actresses, you would have heard the story. After nasal correction, they got more chances and became more popular. One such actress was Sri Devi,
Yes,
for
sir.
whom I gave anesthesia for a nasal correction long back about 25-30 years ago. So that was a fancy thing. For cosmetic reasons also, they do the nasal septal correction. Okay? So the bones that form or the cartilages that form the septum are anteriorly there is a septal cartilage, and this is the portion normally you will find will be deviated, and there is a perpendicular plate of ethmoid and there is a vomer arising from the floor of the maxilla or the palatine bones. So these three are the major important cartilages, septal cartilage. So when this cartilage is bent, you will find the deviation anteriorly, whereas the bending of the ethmoid or the vomer, it is also posterior deviation which may not be visible while you look through the nostrils. So this has to be found out by asking the patient to close the nostril and blow. Then you will be able to identify the presence of obstruction posteriorly, whereas anterior deviation can be visually seen by just inspecting through the nostril itself. So why this knowledge about nasal septum is important? Because sometimes there may be the deviated septum which may need corrective surgery. So this is how the anterior deviation looks like. You can see this lady having a normal nostril opening and there is a narrow nostril opening on this side. This is post-surgical correction. Both the nostrils are almost equal size. So this is how the deviated septum looks like. So if you want to do a nasal intubation, which nostril you will select in this patient?
The right one.
The right one,
Right
yes.
one.
Because this is a very narrow one. If you force the tube through this narrow opening, you will cause more damage. So the anterior deviation of the septum, there is internasal intubation and selection of the wider nostril opening and history of blocked nose by inspection before intubation is necessary. So always ask the patient whether they are able to breathe adequately without difficulty through both the nostrils, including the one alternatively. So post anesthesia nasal blockade also may agitate pediatric patients who are obligatory nose breathers. So if the children have a nasal congestion with an enlarged turbinate bones, you have to be very careful if you do GA because post-operatively there may be a congestion in nasal blockade and children may cry because of inability to breathe through the nostril. Even though pain relief may be adequate, there is no hunger, there is no other reason, but the nasal obstruction may be quite difficult. So some pediatric anesthetists routinely advocate administration of vasoconstrictor drops like Naxivion or Otrivin, dilomethazolin, to reduce the congestion in the nasal mucosa, even if it is not a ENT surgery. Any surgery, even when you do GA for a pediatric patient less than 5 years old, it is always a good habit to apply 2 drops of this nasal mucosal vasoconstrictors like Otrivin or Naxivion. Pediatric drops are available that can be applied so that even the crying before surgery may cause a nasal congestion and produce nasal obstruction. Now, what are the features and functions of inferior concha? Where is this concha?
In the lateral walls.
Lateral wall, excellent. So inferior concha is the longest and broadest of the concha formed by an independent bone. The same name is called the inferior concha. What are the features? Is the longest and broadest that we have seen. What is their function? Why it is present there? It is like a bone which is
Eddy
scrolled.
current.
Not only eddy current, it is mainly for humidification. The concha is covered by mucous membrane that contains large vascular spaces and is one of the three that work to both humidify and clear the air passage into the nasopharynx. So all larger particles or dust particles which are there in the atmospheric air, they will all be filtered there, and also because of the rich vascularity, it humidifies the inspired air. So why humidification is important? What will happen if you keep on breathing dry air?
It will cause crust formation and bleeding. Sir.
It will not allow the not only crust formation in the nose, but also lower down in the respiratory tract. What will happen if you continue to inhale dry gases without humidity? Which other
The
function
ciliary,
will be affected? Ciliary activity.
function.
Very,
So,
yes, the ciliary activity also will be affected, and ciliary function, which is very, very important for removal of the foreign particles and other dust things which have gone down beyond the nasopharynx, lower down to the respiratory tract. So for maintenance of normal ciliary activity lining the respiratory passages and the conductive zone is very important. We should have adequate humidity for it to act. What are the features and importance of superior and middle concha? All of you know that there are three concha: superior, middle, and inferior. And the first thing we saw is the inferior concha, which is the broadest and longest. And there are other two concha, one superior and one middle. What is their role?
Maxillary sinus drains behind
drain
the
the
middle concha. Sir.
Ah,
Behind the middle concha, there is ethmoid bulla and
They arise from the perpendicular plate of ethmoid bone, both of them. Whereas the inferior concha is an independent bone by itself. Whereas the superior and middle concha, they arise from what is called the perpendicular plate of ethmoid bone. And the middle nasal concha is found between the superior and inferior nasal concha and plays a role in humidifying and cleaning as the inferior concha does. And the superior nasal concha is a bony shelf located above the middle nasal concha but below the sphenoethmoidal recess. So this is how the concha are situated. This is the inferior concha. You can see the longest and the independent bone. This is the middle and this is the superior concha. So, and as you said, these openings are there which are important. So now I have shown a picture of some surgical procedure being done. What is this surgical procedure being done here?
function endoscopic sinus
yeah,
surgery.
the right side.
Yes, very good. So they can see the name endoscope written here. So endoscope has been done. This is the sinus filled with the mucosa, and the exit from the sinus is blocked because of the chronic infection. So they remove a part of the bone to facilitate. This is the block pathway before surgery. Then they remove the bone to facilitate drainage of the collections inside the sinus through the nose into the nasopharynx. So this is after the surgery. So this is called functional endoscopic sinus surgery. Now, what are the requirements? If you are asked to give anesthesia, what are all the types of anesthesia under which this surgery can be done?
So local anesthesia and general
General
anesthesia.
anesthesia.
Sir.
Yeah, most of the ENT surgeons who prefer to do it under topical anesthesia by application of local anesthetic solution to that area. As the mucosa is very rich in vascularity, it easily take up the local anesthetic and produce a nasal blockade. But if supposing GA is requested, patient is very apprehensive, they don't want surgery under local and GA is indicated. How to give GA for functional endoscopic surgery? What are all the precautions you
Pre-operatively,
have
you
to
have to
take?
counsel the patient to breathe through the mouth after surgery, sir.
Fantastic, excellent point. That is the first and foremost thing you have to tell your patients for any nasal surgery where there is a possibility that the nose will be kept blocked with packings. So patient has to learn to breathe through the mouth. So you have to counsel and tell the patient that after surgery for a few hours you may have to breathe through your mouth because your nostrils will be kept blocked by packing the nose. This is the first and foremost thing. Otherwise, many patients will become very agitated, restless. Even though your analgesia is good, the hemodynamic status is good, the patient will not be able to explain when they come out of general anesthesia why they are restless. So this is a very, very, very important point that you have to tell all your patients about the need for keeping the nostrils blocked and their cooperation to breathe through the mouth. That is a very good point. Excellent. What else you have to say? Or what else you have to be prepared?
We have to fix the tube on the left side and throat pack to be kept, sir.
You have to keep a throat pack and remember to remove the throat pack at the end of the procedure. That is very, very important. Not only keeping the throat pack to prevent the nasal dribblings or the bleeding or any secretions coming from the nasopharynx into the oropharynx, which will be absorbed by the packing that is done, but you must always keep that tip of that nasal throat pack visible and keep it plastered to the side of the cheek so that you will remember to remove it at the end of the procedure. That is number two. So throat pack will be required before the surgeon starts the surgery. Very good. Any other point?
During extubation, it's always better to keep a oral airway and extubate to
Yeah,
prevent negative pressure pulmonary edema.
very good. That is also a good valid point. Of course, if you have counseled the patient and they have understood that, then the patient may be able to breathe. Once you tell them when they are fully awake, they will be able to cooperate and breathe that. But as a safety precaution, you can put an oral airway also. Very good. Any other special request from the surgeon during surgery?
Tube
Uh,
to be fixed on
Low
the
BP
Huh?
to maintain low
endoscopic tube to be
BP to
fixed on the
avoid
left
bleeding.
side, sir.
They may request for hypotensive anesthesia. Some surgeons may request for hypotensive anesthesia because it is a rich mucous membrane with a lot of vascularity. So, in addition to application of vasoconstrictors, they may also request for hypotensive anesthesia. So, chest surgery is one area where you may need to maintain the mean arterial pressure around 60 millimeters of mercury. So sometimes you may have to use a invasive arterial monitoring. If the patient has got any other associated cardiac ailments also, and the surgeon requests for hypotensive anesthesia, there may be a need for invasive monitoring also. So these are some of the points which you have to remember. One is it may be done under local topical anesthesia or general anesthesia. If you are going to do it under general anesthesia, counsel the patient about the need for breathing through the mouth post surgery. Always try to have an oral airway before extubation. A throat pack may be needed during surgery to avoid soiling, and we must remember to remove the throat pack, and hypotensive anesthesia may be requested. And sometimes post-operative post-nasal bleeding can be a problem. So re-exploration and other things may be requested. So these are all the points that you have to remember with regard to chest surgery. as a part of our applied anatomy. So this is another picture to show more clearly where are the concave. This is the lateral wall of the nose, and it is all related to all the sinuses. The sphenoid sinus, the frontal sinus, maxillary sinus, and why anatomy of the is clinically useful, because sometimes you may get cases of epistaxis also. So, what is which area of the nose is notorious for bleeding? What is that area called?
It's a
It is called Little's area, isn't it? ENT. Long back you would have studied. So whenever there is a nasal bleeding, this is how the nose has to be packed. The layers of gauze soaked in petroleum jelly. So they are all packed in between the groove between the conical bone, the superior, middle, and inferior. So what is this forceps? Speciality of this forceps? The name is written here. This is called a bayonet
it is
forceps.
angulated. Angulated forceps.
So this is a angulated tip. It is not in the straight line with the place where you hold it. Okay, so you will be able to see the tip all the time when you use this forceps. So this bayonet forceps means which other instrument which we use have the same type of angulation?
Michael's forceps.
Nagel's forceps, excellent. So Nagel's forceps which we use, that also has the same amount angulation for you to see the tip, where exactly you are holding the tube and how you are pushing it. So if it is a straight forceps, you will not be able to see the tip because your fingers will occlude the vision. So this is a angulation which is there in this bayonet forceps as well as in the Nagel's forceps for better visualization of the tip. So packing is done for epistaxis. And what is this instrument that is being used to pack the nose? This particular instrument.
Tudicum speculum, sir.
This is a speculum, nasal speculum. Very good. So we can see the gauze has been kept inside and pressurized. So this is one of the ENT instruments which is used for better visualization. And you can apply vasoconstrictors like xylomethylene before instrumentation. So this is the common nasal spray which you see. This is the point I told you, especially in small children. Before general anesthesia, it is always better to put 1 or 2 drops of this nasal decongestant so that the post-operative crying and other things will prevent the nasal congestion and blockage happening. Of course, we have seen that what are all the functions of the trochanter. It increases the surface area of the nasal cavity, so that the amount of inspired air that can come into contact with the cavity wall increases, and they also disrupt the laminar flow into slow turbulent flow. This is another important function. The fast laminar flow with which we breathe in the air is made slow and turbulent so that they can stay there for a longer time to pick up the humidity and also get better filtered. So this increases the humidification. So which are all the openings in the nasal cavity? What are the openings into the nasal cavity? What are all which
Eustachian
sinus?
tube, sir.
Nasolacrimal
Frontal,
duct.
Sinus opening.
axillary, anterior ethmoidal sinuses
Sphenoid
open
and
into the middle meatus. So the 3 sinuses which open into the middle meatus are frontal sinusal, axillary, and anterior ethmoidal sinus. The middle ethmoidal sinuses empty into a structure called ethmoidal bulla. The posterior ethmoidal sinuses open at the level of superior meatus. So ethmoid has got 3 sinuses: anterior, middle, and posterior. Whereas frontal and maxillary are on either side of the nose, and majority open in the middle meatus. The only structure not to empty into the lateral walls is the sphenoid sinus. It drains into the posterior roof of the nose. And nasolacrimal duct, which drains tears also opens into the inferior meatus, and Eustachian tube opens into the nasopharynx at the level of inferior meatus. So inferior meatus, we have two openings. One is the nasolacrimal duct and another is the Eustachian tube or auditory tube. So these are all the various openings which are seen. Ethmoidal bulla opening, semilunar for maxillary and anterior ethmoidal. So all these openings are Eustachian tube in the inferior meatus, and also the nasolacrimal duct, which is not shown here, that also opens in the inferior meatus. Describe the nasal innervation. This is a very important point as anesthesiologists we should know for achieving good analgesia of the nose and the inside of the nose as well as outside of the nose. Which are all the nerves which supply the sensory to the nose?
So inferior
Mr.
orbital nerves.
Inferior orbital, infraorbital or inferior orbital?
Infraorbital.
Infraorbital.
Infraorbital. Then, so
Uh,
nasal innervation can be simplified by
branch.
dividing into internal and external. So the innervation of the nose, you have to first divide it into external skin sensation and internal. Mucosa is also very sensitive. So you have to divide that into internal, that is mucosal surface innervation, and external skin surface innervation. So the external nose is innervated by the ophthalmic branch and maxillary branch of the trigeminal nerve. So V1 and V2, the fifth cranial nerve, ophthalmic and maxillary branches of the trigeminal nerve supply the external nose. The superior aspect of the nose, including the tip, is supplied by infratrochlear nerve, the supratrochlear nerve, and the external nasal branch of anterior ethmoidal nerve, which all arise from the ophthalmic division. So the ophthalmic division gives rise to three branches. One is infratrochlear, supratrochlear, and external branch of the ethmoidal nerve. Whereas the infraorbital nerve, which is a branch of maxillary nerve, supplies the inferior and lateral aspects of the nose, extending to lower eyelids. So this is the picture. You can see the V1 or ophthalmic division, supratrochlear, supratrochlear, and the external branch of ethmoidal nerve. These three come from the ophthalmic division. You can see almost they are in a straight line. And this infraorbital nerve is a branch of maxillary division of the trigeminal, V2. So the four nerves, these are the four nerves which supply the external nose. And the internal nasal cavity is subdivided into nasal septum, lateral wall, and the cribriform plate. These are the subdivisions of the internal nasal cavity. So the superior inner aspect of the lateral nasal wall is supplied by the anterior and posterior ethmoidal nerves, which are again branches from the ophthalmic division. Then the sphenopalatine ganglion, which is a branch from the maxillary division, is located at the posterior end of the middle turbinate and innervate posterior nasal cavity. The anterior and posterior ethmoidal nerves and the sphenopalatine ganglion provide sensation to most of the septum also. So the cribriform plate holds a special sensory branch, that is the olfactory nerve, cranial nerve 1. So cribriform plate is the special sensory branch, olfactory also is there inside the nasal cavity. So this is very important. So if you want to do any rhinoplasty under local anesthesia, if your surgeon is not well versed with the blocking, you must tell him where all to block. This is supratrochlear, you have to block here at the medial end of the eyebrow, just below that. Then infratrochlear will be at the root of the nose. The external branch of ethmoidal will be almost on the middle of the nasal bone, and infratrochlear nerve will be in line with the pupil, so below the lower margin of the orbit. So if you block all these four nerves, you can do the rhinoplasty comfortably, and all the internal nasal cavity can be blocked by packing the nose with local anesthetic soap gauze piece like what I showed in the earlier picture. That application, surface application itself will block all these mucosal nerves and we can achieve a very good anesthesia inside the nose also. So this is the branch. You can see anterior ethmoidal nerve, posterior ethmoidal nerve, septal branches, nasopalatine. So remember these three nerves which are supplying the entire nasal septum and the internal cavity of the nose. Then comes the important thing, what is the blood supply of the nose and why it receives such a rich blood supply. Roughly, which are all the vessels which should be supplying the nose?
Ethmoidal
Palatine
artery.
artery, superior pharyngeal artery, inferior palatine,
Superior labial artery, splenopalatine artery.
Palatine artery.
anterior ethmoid.
The rich vascular supply is mainly for providing humidity and raise the temperature of the inspired air. These are the two functions done by the nose. Okay? So it provides adequate humidity. Sometimes the examiners ask you about the types of humidity. How will you classify humidity? Any idea? Absolute humidity and relative humidity. Okay. So
Yes, sir.
absolute and relative humidity. That is also, this humidity factor is also important in maintaining the humidity inside the operation theater also. Environmental maintenance. You have to know how much of humidity should be there inside the OT so that the surgeons and other people do not sweat. The sweat doesn't fall onto the patient. So for that we must know how much humidity should be maintained inside the OP also. One of the important things we have to know in giving advice to the construction of a new theatre. You may be consulted as a in charge anesthetist to find out how much humidity, how much of filtration, HEPA filters are being used, and then you have the airflow systems which tell you about the laminar flow of the turbulent flow. All these things you have to read about before you go to your exam. So it is the blood supply is from internal and external carotid artery branches. The branches from internal carotid are anterior ethmoidal artery, posterior ethmoidal artery, and these are the branches of ethmoidal arteries are branch of ophthalmic artery. They descend into the nasal cavity through cribriform plate from above. Whereas the external carotid branches, sphenopalatine artery, greater palatine artery, superior labial artery, and lateral nasal arteries. The venous drainage is by pterygoid plexus, facial vein, and cavernous sinus. So this cavernous sinus communication is very, very important because any infection in the around the tip of the nose, the columella, that area, there is a communication with the cavernous sinus, and any infection there and not properly treated can spread on to the cavernous sinus and produce what is called a cavernous sinus thrombosis, which is a very, very grave intracranial pathology. So few nasal veins join the sagittal sinus also. This represents a potential pathway which can cause infection inside the cranial cavity from the nose. Okay? And this is what is called the little's area, where all the anterior sphenopalatine and labial arteries, all these arteries conglomerate here, and so this is the notorious area for bleeding causing epistaxis. So the little's area is supplied by both anterior posterior ethmoidal, sphenopalatine, and superior labial septal branches. And of course, the communication with greater palatine artery is also there. So remember that nose is supplied by branches from both internal and external carotid branches. That is the reason why any injury, trauma in the face, nose bleeds like hell. So nasal bleeding will be very, very serious. And this is the area which has got a communication within the cranial cavity, which can produce or transfer the infection from the nose to the intracranial area. What are the causes of nasal airway obstruction?
So foreign bodies, sir.
Foreign body
Deviated nasal
obstruction.
septum.
Deviated nasal septum.
Natural causes, yes.
Turbinate.
Formed and supported by bones of skull, so needs no internal artificial support to keep it open, but it becomes easily obstructed by congestion or edema of the mucosa, especially in children. Adenoid lymphatic tissue in the nasopharynx can cause chronic obstruction in children. An upset or crying child will often have a congested blocked nose. This may be first apparent during induction of anesthesia. So the remedy is to place an oropharyngeal airway. If the patient is slightly anesthetized, use a short one to avoid gagging, and your only aim is to part the lips and allow oxygen to pass into the oropharynx. Sometimes this can be a very serious problem if you don't know this simple maneuver to open the airway during pediatric anesthesia. So you have to be quite aware of that. In elderly patients with no teeth, a similar situation can occur when chin lift maneuver causes the chin and lips to overlap the nostrils. So normally we do the chin lift in patients to have a good mask fit during ventilation. But in edentulous patients, if you do a chin lift, what will happen? This is how the whole obstruction will be caused. So this patient has got no teeth at all. Sorry. And when you try to do a chin lift, the upper lip completely occludes the nasal openings and produces an obstruction. So how to prepare the nose by topical anesthesia and medication before you do a nasal intubation or a nasal endoscopy?
We can give
We can pack
vasoconstrictor
nose
drops.
using local anesthesia, sir.
One at a time.
Nasal pack, anterior nasal packing, sir, using topical anesthesia.
Nasal insertion of a nasal airway, nasotracheal tube, or a fibroscope. It is advisable to use a topical vasoconstrictor in order to open the airway and prevent mucosal damage. Number 1. Vasoconstrictors such as xylomethicillin can be used, but it takes several minutes to work. So you must apply it sufficiently early. So it is not that you just put 2 drops and immediately insert your airway. So you have to give sufficient time for it to take effect. And 4% lidocaine is suitable topical anesthetic for nose, pharynx, and larynx. And you can either drip it as a local anesthetic from a two-channel syringe, or split it with a fine needle attached to the syringe, or use an atomizer using oxygen flow can also be used for even spread of local anesthetic. So this is the most convenient method both for the anesthetist as well as the patient. So you can use the atomizer or the common we call that inhaler for patients to inhale the local anesthetic, which is broken down to small particles with an oxygen flow. That also can be done. What is the indication and contraindication for nasal airway devices?
Base
When
of
should
skull,
you not use base of skull fracture? Very good. So nasal airways are better tolerated in semi-conscious patients than oropharyngeal airways. So patient recovering from anesthesia not fully conscious, nasal airway is better tolerated than oral airway. And do not use nasopharyngeal airway in head injured patients. There is a risk of basal skull fracture. There is a risk of introducing not only infection, but the tube itself can enter the cranial cavity sometimes, especially if the cribriform plate is damaged and your nasal airway can go through that gap into the cranial cavity. When is the nasotracheal intubation needed? Sorry, how much more length is needed?
When the surgery involves head and neck procedure and constant.
Any intraoral procedure, mostly intraoral procedures, we do nasal intubation, isn't it? Any
Yes, sir.
dental or any tongue malignancy, cheek oral cavity malignancy, for all these things, we prefer to any surgery in the oral cavity, nasotracheal intubation may be requested. And what should be the extra length needed compared to the oral for an
2
adult?
to 3 centimeters.
2 centimeters.
2 to 3 centimeters more. The use of nasal tube allows free surgical access to the mouth. It's helpful to surgeon in dental, maxillofacial, plastic, and some ENT cases. A nasal tube normally needs to be 2 to 3 centimeters longer than oral tube. Blind nasal intubation can be valuable rescue technique in case of unexpected difficult laryngoscopy. What preparations are needed for nasal intubation under direct vision? We are going to do a nasal intubation with a laryngoscopy. What are the preparations you have to make? Or what are the
We
instruments
need
you
to
require?
use
Hmm?
we need to use vasoconstrictors in the nasal area and some topical infiltrates. We can also use local sprays, lignocaine sprays, and
We have to dilate the
af-
nasal cavity and we
uh,
should use lignocaine jelly over the tubes.
we ideally
Lubricated
need to
tube
check
well.
for the long, wider nasal cavity.
Very good. Select the wider nostril. Excellent.
Select a correct
And we
size of
can
the tube,
dilate
sir,
the
ET tube.
Hmm?
Selecting a correct size of the ET tube, sir.
Correct. Right. One
With
size
the use
smaller
of
will
McGill's-
always be preferable than
Using
oral.
McGill's forceps, sir.
Use of McGill's forceps. Any other preparation with the conventional disposable plastic tubes, which we PVC tubes, which we use? Do you have to make any other preparation for nasal intubation? These PVC tubes a little harder or softer?
Harder.
Harder. So can you make it little softer before you do a nasal intubation?
Yes, sir.
How?
We can just bend the tube, sir.
You can dip it in warm water for a few
Okay.
minutes so that it will become softer. Okay. Always use a well lubricated tube. Soften the tube 30 seconds by immersion in warm water. Bend the tube to insert the bevel into the connector and leave it for a few minutes to reduce the Nagel's angle. What is the Nagel's angle? So this is how you have to bend the tube and insert the tip into the connector and leave it like that for a few minutes so that it becomes more acutely bent. So normally when you don't do this, it will have a larger 140-degree angle. Okay, the Nagel angle is normally about 140 degrees. So you make it much more acute by bending this so that it will align itself well through the nasal curvature and go without any injury to the nose. So although some resistance is common, never use excessive force. If you are unable to advance the tube through the nose, check the angle of insertion, whether it is parallel to the floor of the nose, and try a gentle rotation of the tube or try insertion through the other nostril or use a smaller size tube. So these are all the alternatives. When you are not successful in introducing the tube through the nostril you have selected, these are all the alternate things that you have to do to succeed in nasal intubation. What is the current technique of local anesthesia for fiber optic nasal intubation?
As you
Spray as you go, sir.
Spray as you go. Very good. Spray as you go technique. How to confirm the correct placement of ET tube by fiber optic bronchoscope?
by visualizing the carina and 2 centimeters above carina.
Excellent, very good. So visualization of carina and two major bronchi indicate the correct position of the EP tube in the trachea. So this is how you must be able to see the picture. So this is the carina, center septum like thing. This is the left main bronchus, this is the right main bronchus. So if you are able to visualize this through your bronchoscope, that means your tube is well away from the branching of the trachea into the two major bronchi. So that is the correct location that you have to leave it. What are the advantages and disadvantages of nasal oxygen therapy?
It
This
can
is another
provide
application. Yes.
apneic oxygenation during our procedures and can increase the FRC.
So normally we give nasal oxygen in the
Patient
post-op
comfort
or
will
in
be there,
ICU.
sir.
It allows the patient to eat
Patient
and
comfort will
speak
be there.
comfortably, sir.
So nasal oxygen allows patients to eat, talk and cough normally, number one. If songs are used, the nose can do the job of humidification and warming, and a separate humidifier is not needed. High flow gases require increased FiO2. To increase FiO2 can dry mucosa and cause discomfort. This is one of the disadvantages of high flow nasal oxygen. And what surgeries are performed on the nose or through the nose? How anesthesia administered for them?
Most of the FES
Septoplasty.
surgeries, septoplasties,
Septoplasty
DCR,
and turbinate
turbinectomy, breast surgery.
rhinostomy.
These are all ENT procedures. What other procedures can be done through the nose?
Pituitary.
Neurosurgical
endoscopic
procedures.
pituitary.
Okay, so you can do rhinoplasties. Open or closed rhinoplasty can be done under local anesthesia or topical infiltration anesthesia. So the knowledge of sensory innervation, both external skin sensation and internal nasal mucosal sensory innervation is very important. Means oral intubation with a throat pack. For all the rhinoplasties, we have to do via oral intubation, preferably with a oral ray tube, so that it doesn't project during the surgeon's doing the surgery. And a throat pack also can be used to avoid blood getting aspirated into the lungs. Then transsphenoidal pituitary excision. This is one of the neurosurgical procedures done through the nose. So intubation is done with either oral cupped ray tube or a flexometallic tube. Again, you have to do a throat pack. And chest and septoplasty surgery is done by the ENT surgeon. Again, oral intubation, throat pack, and request for hypotensive anesthesia to relieve bleeding, or sometimes infiltration with epinephrine solution. Surgeon has to know what is the correct dilution you have to use. So if the surgeon is not aware of it and he is asking you, doctor, how much of epinephrine can I use? How will you advise him?
5 mg per ml, we will advise, sir.
1:2 lakh.
How do you prepare that 5 mg per ml?
Sir, 1:100, sir. First, we have to take 1 ml of adrenaline and we have to dilute it with 9 ml of distilled water. So 1:100 ratio. 1 ml, 100 mg will be there, sir. So we have to calculate about the amount of ml they are taking, sir. If they are taking 20 ml of local distilled water with lignocaine, we have to give 20 into 5, sir. 100
Very easy
mg
method is to add
them.
1 ampule to 200 ml of saline. That is as simple as
Okay.
that. Okay. So you can add 1 ampule, which is 1 in 1000 or 1 milligram, that is 1000 micrograms, added to 200 ml of normal saline. Then 1000 divided by 200, each ml will be 5 micrograms. So surgeon can use up to 5 microgram per kg body weight. So if he is a patient who is a 70 kg person, you can use 70 ml of that diluted solution. Okay, so if to cover larger areas, it will be useful to dilute it with 200 ml of normal saline. So always advise the surgeon to go for a larger dilution instead of this smaller dilution, so that errors can be avoided. So it is always safe in the theater where they do multiple surgeries using this. You can prepare this in a saline bottle, discard 300 ml and add 1 ampule to that, label that and ask them to withdraw from that and use it repeatedly. Okay, so 1 ml added to 200 ml of normal saline will give the ideal dilution of 5 microgram per kg per ml, and 5 microgram per kg body weight can be safely used to produce a local effect without any systemic effect of tachycardia and hypertension. Now, next comes is a very common thing about larynx, anatomy of the larynx. Describe the anatomy of the larynx. This is another common anatomy question that is repeatedly asked in the examination. Both in theory as well as in practice, they will ask you about the various types of larynx injuries.
It
What
is
are the
divided into 3 parts: nasopharynx and oropharynx and pharyngolarynx.
pharynx or larynx?
Supraglottic,
Okay, sir. Larynx.
supraglottic,
Inlet is formed by epiglottis.
Supraglottic, glottic, and subglottic.
glottic and
These are the 3 main divisions of larynx: supraglottic, glottic, and subglottic. So it is a segment of the respiratory tract located in the anterior aspect of the neck. Okay, that is the description. It is about 4 to 5 centimeter in length and width, with slightly shorter anteroposterior diameter. The location of the larynx is at level of cervical 4 to 7 in adults, held in position by muscles and ligaments. And the superior most region of the larynx is the epiglottis, that is attached to the hyoid bone connected to the inferior part of the pharynx. The inferior aspect of larynx connects to the superior region of the trachea. So just below the cricoid cartilage starts the trachea. So up to that it is the larynx. So the laryngeal skeleton is made up of 9 cartilages. The 3 of them are unpaired cartilages. The thyroid, cricoid, and epiglottis are the single cartilages or unpaired cartilages. And there are 3 paired cartilages: arytenoid, forniculate, and cuneiform cartilages. So totally they make about 9 cartilages. This is the bony framework for the larynx. So this is the picture to show you all that. This is the epiglottis, this is the thyroid, this is the cricoid. So these 3 are unpaired cartilages, single cartilages. And this is the arytenoid, which is paired. Then there is a cuneiform and corniculate, all attached to more or less this arytenoid cartilage. So they become the paired cartilages. And this is another picture to show how you divide it into supraglottic, glottic, and subglottic area. So supraglottic consists of all these parts: the epiglottis, the aryepiglottic fold, the ventricle of Morgagni, and part of the arytenoid is there. And glottic opening is mainly made up of the vocal cord, which is the inlet point to the lower down passage of the larynx and trachea. And below that you have the subglottic, which is the mainly cricoid region. So these are the 3 divisions of the larynx. So what are the structures which comprise supraglottis? We saw in the earlier picture there. So connects larynx to the base of the tongue. So the purpose of the supraglottic area is it connects the larynx to the base of the tongue. Extends up the ventricle divided into epiglottis, aryepiglottic fold, arytenoid, false vocal cord, and ventricle, and mucosal lining made by stratified squamous epithelium. And it is rich in lymphatics, which exit through thyroid membrane to jugulodiaphragmatic nodes, and cervical metastasis more common here. From this area, the laryngeal cancer, cervical metastasis arise mainly from the supraglottic areas. The epiglottis, of course, all of you know, it is like a leaf-shaped fibrocartilage. It's not a simple cartilage, it's a fibrocartilaginous structure. It has a narrow base and attached to the thyroid cartilage, two surfaces. It has a laryngeal surface and a lingual surface. So the nerve supply to these two areas are slightly different. Okay? The laryngeal surface and lingual surface are supplied by different nerves. In suprahyoid epiglottis, free and infrahyoid epiglottis, there are numerous bits related to the face, and this is how the whole thing looks like. Now, what is the difference between adult and pediatric epiglottis? This is the common question, especially if you have a pediatric patient, they may ask you this question very routinely. In what way the pediatric epiglottis differs from the adult epiglottis?
It is omega shape and floppy in pediatrics.
Situated,
The narrowest portion differs.
so this is how the adult epiglottis looks like. It's a more broader and almost a rectangular structure, whereas this is a very small folded. So unless you include the epiglottis, you cannot see the vocal cord, the opening here in children. Whereas here you can just keep the tip of the blade in the space called vallicula before the epiglottis and lift it so that you can see the entire thing. So that is the practical application they always, that is why you have straight blade to include the epiglottis for pediatric intubation, whereas we prefer to use the curved blade for adult patients. So this is the practical application of this knowledge about adult and pediatric epiglottis. What is the anatomy and functions of periepiglottic fold? What does it do?
It closes the larynx while while swallowing.
It extends from arytenoid cartilage to the epiglottis. Okay, contains carniculate and cuneiform cartilage. It is flappy. In laryngomalacia, it will be flappy, and all these three structures, periepiglottic fold, pars cords, and true cords, form three sphincters during pharyngeal phase of swallowing. So this fold is very important for closing the larynx while we do the swallowing by covering the epiglottis over the inlet of the larynx. Otherwise, we will be aspirating all the time. Okay, so the main function is to prevent aspiration. So this is how the whole thing is there. So this is the vocal cord. This is the periepiglottic fold. So this is the epiglottis, this is the arytenoid cartilage. So it is connected to that. So it pulls the epiglottis down while you are swallowing to cover this entire thing. And it contains the carniculate and cuneiform cartilages also embedded into that. So these are all about the false and true vocal cords. So what constitutes the glottis, which is the entry point below the vocal cords? What are the structures which constitute the glottis? It comprises of true cord and posterior commissure. Rima glottis, which is a triangular space between two vocal cords and extends 1 centimeter below free margin of vocal cords and narrowest portion in the adult larynx. So this is the epiglottis. All of you will see this is the space between this true vocal cord and this sheet, which is the false vocal cord, is called the ventricle. And this is the arytenoid cartilage. You can see the small projections which you will be sometimes seeing when you do intubation. This is the base of the tongue. So this is the actual glottic opening. So this is the gap through which we pass our endotracheal tube or your fibroscope. All these things are passed between this. And in normal respiration and phonation, this is the most important structure for adjusting your air entry as well as phonation. So what is true vocal cord attached to and what is its structure? Where is the true vocal cord attached and what is its structure?
Attached to
vestibular.
thyroid cord.
Vocal cord. It is the anterior 2/3 is membranous and made up of vocal ligament and muscle, whereas posterior 1/3 is a fibrous structure. Vocal processes of arytenoid is attached that. So this is the arytenoid process, and this anterior 1/3 is made up of vocal ligament and muscles. Posterior 1/3 is by fibrous tissue. Vocal cord inserts into the midline of thyroid cartilage via Broyles ligament. This portion gets attached to the midline of the thyroid cartilage. So at the level of insertion, inner perichondrium is absent, and Broyles ligament limits the inferior spread of glottic cancer. So the supraglottic cancer spreads to other areas, whereas the glottic inlet cancer will not spread too much. It will be limited to this ligamentous structures alone. So this is how the whole picture looks like. The thyroid muscle and the lower portion is mostly fibrous. And this is the thyroid cartilage. So the tip, the smaller narrow portion gets attached to the thyroid cartilage in the middle line. So this is how the membranous portion and cartilaginous portions are there. And this is the glottic opening. So this is again the arytenoid cartilage to give you another view of what is it. This is called the anterior commissure, and this is the posterior commissure. Sometimes when you do a nasal intubation, the tip of the tube will be going and hitching to this anterior commissure. So you make a 90-degree rotation to bring the bevel down, then you will be able to insert the tube into the cavity. So whenever the tube gets stuck to the anterior commissure, you have to pull it down, rotate it 90-degree, make the bevel come facing the posterior aspect of the larger opening and push it in, then you will be able to integrate. So that is a practical application of this knowledge about this commissures of the opening. What is the surface marking of anterior commissure and what anomaly may occur in this? Already I showed you the picture where it is getting attached to the thyroid cartilage in the midline. So how do you mark it in the surface?
Thyroid prominence.
Anterior commissure is the area between the two vocal cords. Surface marking of AC is in the male, it is the midline between thyroid notch and the lower border of the thyroid. Whereas in the female, it is the upper 1/3 junction of upper 1/3 and the lower 2/3. So it is slightly higher in female, whereas it is almost in the midline between the thyroid notch and the lower border of the thyroid cartilage. So if somebody asks you to mark the attachment of anterior commissure from outside, you will have to palpate the thyroid cartilage, and in the adult you have to mark the midpoint between the thyroid notch and the inferior border of the thyroid cartilage, whereas in the female it will be upper 1/3 and lower 2/3 junction. And webbing is a more common anomaly that can happen especially in children. So this is again the picture how to show that. What is the role of posterior commissure and where is it present? Anterior commissure is this, what we see here, attached to the thyroid cartilage.
It is
So,
attached to the arytenoid cartilage.
very good. So it is the area between the vocal process, is the respiratory portion. So this is the posterior portion is the one which moves widely to allow the air to go in or even during phonation. And posterior commissure scarring mimics bilateral abductor cord palsy. So this is the normal larynx. This is called the posterior commissure. This is the proximal trachea. This is the true vocal cord. This is the anterior commissure, and this screen-like thing is the false vocal cord attached by the side of the true vocal cord. So what is the extent of subglottic area and how it is divided? So we saw supraglottic, glottic. Now we have come to subglottis. So how do you divide the subglottic area? What is the section?
Inferior part of the vocal cord to C6.
It extends up to lower border of cricoid cartilage. Okay, from the glottic opening to the inferior border or the lower border of cricoid cartilage. It has a mobile upper part below the vocal processes to upper border of cricoid cartilage. That is the upper part of the subglottic area. Then there is a fixed lower part which extends up to the inferior part of the cricoid cartilage. So cricoid cartilage up to upper border, it is a mobile part. Below that, it is a fixed part of the subglottis. So you can see this is how the areas are there. The vocal fold is there, vocalis muscles, intraglottic space. So you can see this is the cricoid cartilage. This upper portion is a mobile portion, whereas this lower portion from the tip to the lower border, it is a fixed portion of the subglottic area. And normally this is little dynamic. This is a normal fixed anatomical area. Any edema in this area will be causing airway obstruction, especially in children, because the mucosa is very lax and oversized tube or compression for a long time will produce mucosal edema, which will narrow this portion much more to cause what is called the subglottic obstruction. So, how does pediatric subglottic area differ from that of the adult? This is a valid normal change that the examiners want you to observe. So, in the adult, if you see the entire larynx is about like a cylinder. This is the thyroid cartilage, this is the cricoid cartilage. So, from the inlet down up to the subglottic area, it is of almost uniform size, cylindrical. Whereas in pediatric patients, the largest opening is at the glottic level, but subglottic area, it becomes more conical or a converging thing. So it becomes like a funnel. So it becomes like a funnel shape. So this is the area which is prone for edema and obstruction, especially if you try to force a larger size tube through this narrow passage, then post-op when you extubate, the child may develop a post-extubation obstruction. So why subglottic stenosis occur in pediatric patients? Why upper half stenosis is difficult to treat? Supposing patient develops subglottic stenosis because of prolonged intubation, what is the reason pediatric patients develop? I told you earlier, the reason is subglottic stenosis is more common in pediatric airway due to non-expansile ring. So the cricoid ring is very stiff, and the lower half you can deal by resection and anastomosis, whereas upper half, as I told you, is difficult to treat because arytenoids limit the resection. So there is an attachment of the arytenoid cartilage to the cricoid, so that will limit the resection. So upper subglottic stenosis is more difficult to treat than lower subglottic. And what is the meaning of thyroid and the angle formation of lamina? It is a shield. Thyroid means shield. So it is like the Roman soldiers who hold the shield. Most of you would have seen those pictures. So because it resembles that, it is called a thyroid cartilage. And in the male, it forms an acute angle. The Adam's apple is more prominent in male because of the acute angle formed by the two laminae of the thyroid cartilage. Whereas in female, it is more obtuse, 120 degrees, so doesn't form any angle or become prominent like that. And the peculiarity of cricoid cartilage is it is a signet ring shape. Anterior arch is 5 to 7 millimeter. Posterior lamina are 2 to 3 millimeter. And cricothyroid joint related to recurrent laryngeal nerve. So this is how the whole cartilage looks like a signet ring. You can see this is anteriorly it is more broader, whereas posteriorly it is very thin, very small. So this is the anterior aspect, this is the posterior aspect, and this is how it is articulating with the arytenoid cartilage. So the anterior aspect of the cricoid and arytenoid, how they articulate with each other. What are the parts of arytenoid cartilage and why we should know about this arytenoid cartilage?
It has the attachment to intrinsic muscle and the vocal cord.
Okay. How do you describe the parts? It is all of you have been seeing the pictures. It is almost like a pyramid shaped thing. Arytenoid is something like a pyramid with a almost triangular process. So it has got the three process. The same picture which I showed you, it is an apical process, that's a muscular process and a vocal process. So this is how the arytenoid cartilage looks like. So it has got three processes: apical, muscular, and vocal process, and it articulates with the cricocartilage below. So forms a synovial type of joint with this particular thing. So what are the injuries caused by the arytenoid cartilage? Causes of injury to arytenoid cartilage. How can injury occur to arytenoid cartilage? And what is its effect?
Intubation itself can.
Intubation, faulty position. So protrusion of an endotracheal tube stellate, an unanticipated difficult airway leading to prolonged or traumatic intubation, or a use of gum elastic bougie, blind intubation techniques without with like a lighted slit or lighted van, and insertion of bulky double lumen tubes. All these things can cause arytenoid cartilage injury. And when it is injured, what will happen? What will be the effect of injury or a fracture to arytenoid cartilage? Chronic corticosteroid use, laryngomalacia, acromegaly with an elevated BMI also can be independent risk factors, as well as transesophageal echocardiography. These are all the causes of injury to arytenoid cartilage, and the effect will be hoarseness of voice, difficulty in swallowing, and pain in anterior region of the neck. These are the things that will be caused. Very rare. Of course, cases have been reported where arytenoid cartilage injury has occurred because of all these conditions. So what is the role of this other two paired cartilages, corniculate and cuneiform cartilage? Do they have, you saw in the earlier picture, they are almost in line with the arytenoid cartilage in the area epiglottic fold. They are situated there. So they are vestigial structures which are present in the area epiglottic fold. They tend to thicken the area epiglottic fold when used for resurfacing larynx after vertical hemilaryngectomy. So that is the only use for that. How are the muscles of larynx classified and what are their functions? So we saw about the cartilage all this time, about the paired and unpaired cartilages. Next comes the next anatomical structure covering the larynx is the muscles of larynx. So how do you classify the muscles of the larynx?
They can be divided into intrinsic and extrinsic muscles.
Very good. So you have to classify them as extrinsic and intrinsic muscles. So what are all the extrinsic muscles? Can you name a few extrinsic muscles?
Sternocleidomastoids.
Thyroid.
All the strap muscle, mostly the strap muscle. Extrinsic muscles can be further divided into suprahyoid muscles, which are stylohyoid, geniohyoid, mylohyoid, and thyrohyoid, digastric, and stylopharyngeus, which are elevators of the larynx. They help in pulling the larynx up. Whereas the infrahyoid muscles are omohyoid, sternothyroid, sternohyoid, and thyrohyoid, which are lower larynx, and to a minor degree alter the laryngeal shape, and the intrinsic muscles control the vocal cords. The main function of intrinsic muscles is the control of vocal cords. What is the nerve supply to the intrinsic muscles of the larynx? So we have to know more in detail about the intrinsic muscles which are controlling the function of the vocal cords, like abduction, adduction, tension. What is so the nerve supply? Usually the damage caused to the nerves affect the function of the vocal cords, which result in post-op respiratory obstruction problems. So we have to know all about the intrinsic muscles nerve supply.
All the muscles are supplied by recurrent laryngeal nerve except cricothyroid, which is supplied by external laryngeal nerve.
Very good. All intrinsic muscles of larynx are supplied by the recurrent laryngeal nerve, except for cricothyroid, which is supplied by the external branch of the superior laryngeal nerve. So this is a very simple answer. The exam they definitely ask you about this. All the intrinsic muscles except cricothyroid, that is the muscle attached between the cricoid and the thyroid cartilage, they are supplied by recurrent laryngeal nerve, whereas this cricothyroid alone is supplied by external branch of superior laryngeal nerve. So if this knowledge is known, you can find out how they are working, how these various actions of that. So intrinsic muscles coordinate phonation, respiration, cough reflex, and act as a sphincter mechanism. They are all paired muscles. There is only one unpaired muscle which is called arytenoideus. And the cricothyroid muscle, its function is to mainly it's a tensor of the vocal cord. It originates from the cricoid arch, insertion into the inferior border of thyroid cartilage. So that is why it's called cricothyroid. Origin from the cricoid arch, insertion into the inferior border of thyroid cartilage. This tilts the thyroid forward and cricoid backward, stretching of the vocal cord, make it more tense. So whenever you want to sing in a high pitch, you have to, this is the muscle which helps to achieve the pitch. And it is supplied by the external branch of the superior laryngeal nerve. Rest of all the other muscles are supplied by the, so this is how the action of this muscle, cricothyroid, is done. And this picture gives you an idea about what are all the muscles that are there to cause the various actions. One is abduction, another is adduction, third is the tension. These are the three actions of the vocal cord muscles. Okay? So the abduction is by what is called the posterior cricoarytenoid. And the adduction, there are four muscles for adduction. This point of anatomy is very important because for moving the vocal cords away from the midline for abduction, there is only one muscle. Whereas bringing the vocal cords towards the midline to cause adduction, you have four muscles: cricothyroid, lateral cricoarytenoid, interarytenoid, and thyroarytenoid. So all these four muscles are there. So you can imagine if there is even a small injury to the adductors will become more forceful and they will bring the vocal cords towards the midline to cause a complete obstruction. That is the reason why the abductor palsy is very dangerous, because the adductors will be spared and they will cause complete obstruction. And tensure or the vocal cord is tensed by the cricothyroid and vocalis, which is a part of thyroarytenoid. This is more for producing high pitch. It doesn't have much function on respiration, but during phonation or singing, this is very important. So mainly we have only one abductor and four adductors are there, and you can see this is the cricothyroid, which is also having a partly adductor function, is supplied by the superior laryngeal nerve. All the others are by recurrent laryngeal. So that picture will be helpful to remember this. This is the mnemonic you can remember. The posterior to clip, you see a valley. So the posterior cricoarytenoid is the abductor. Only muscle, posterior cricoarytenoid is the only abductor. All other cricothyroid, lateral cricoarytenoid, interarytenoid, thyroarytenoid are all adductors, and tensors are by the cricothyroid again. So what is unique about posterior cricoarytenoid muscle?
It is the only
It is
muscle
the
available for abduction.
only abductor of vocal cord, origin from the posterior surface of cricoid lamina and insertion to the muscular process of arytenoid, and action vocal cord abduction, and the nerve supply is from recurrent laryngeal nerve. So what happens in partial recurrent laryngeal nerve palsy? Which muscles control the pitch of the voice? What controls the intensity of voice? Supposing you have a partial injury to recurrent laryngeal nerve, as commonly happens during a thyroid surgery, what will happen to the patient? Which muscle will be affected most in partial injury? We have only one muscle to cause abduction,
Cricoarytenoid.
isn't it? So see, the recurrent laryngeal nerve palsy, the cord assumes median or paramedian position due to cricothyroid overactivity. The pitch is related to tension of the vocal cord, that is by cricothyroid thyroarytenoid muscle, and the intensity of the voice respiratory effort by subglottic pressure. So the intensity or gruffiness of the voice has nothing to do with the vocal cords. It is mainly because of the subglottic pressure that is created. Describe the origin and divisions of superior laryngeal nerve. Where does it arise from? And we saw that there is a branch which supplies the cricothyroid. It is a tensor of the vocal cord.
It
So
is the
where
branch
does it
of
arise?
vagus nerve divided at the level of base of skulls.
Yeah, it's a superior, separates from the vagus just outside the jugular foramen, okay, at the inferior vagus ganglia. At the level of hyoid, it divides into internal and external branches. What are the functions of internal and external branches of superior laryngeal nerve? What is its clinical importance?
Internal laryngeal nerve supplies the sensory portion above the vocal cords.
Very good.
External supplies the cricothyroid muscle, which is the tensor of
Cricothyroid muscle. Excellent. Internal branch passes through the thyroid membrane and provides sensory innervation to the vocal cord. So this is what we try to block from externally while trying to do any airway instrumentation. If you want to abolish the vocal cords closing while you do the intubation or your fiber optic intubation or fiber optic examination, you can block the internal branch by injecting 1 to 2 ml of local anesthetic below the hyoid conva into the thyroid membrane, where this internal branch pierces and goes and supplies sensation to the vocal cords, sensory innervation. And this branch can be blocked from outside injecting LA drug through thyroid membrane. And the external branch supplies the cricothyroid muscle. What is the course of recurrent laryngeal nerve and what is the clinical importance of that?
it
This is
runs
the same
lateral to
both
the
sides.
lateral to the thoracic part of esophagus, and it goes and take a turn in the arch of aorta on the
Both
left
sides
side.
or
Left
one
side
side?
Left
recurrent
side,
laryngeal.
sir. And it
The
supplies the
recurrent means it winds round. That's why it's called recurrent, because it comes down, then turns back and goes up. So both the sides it is doing that. Recurrent laryngeal nerve branches from the vagus in the thorax and loops around the arch of aorta on the left side and the subclavian artery on the right side. So it loops around the arch of aorta on the left side and subclavian artery on the right side before traveling back between the esophagus and trachea to supply all the intrinsic muscles of the larynx except cricothyroid, and also sensation to the larynx below the vocal cords. So it provides sensory innervation to the trachea, upper larynx and trachea, that is subglottic area and tracheal areas below the laryngeal entry. So Ortner's syndrome is a hoarseness due to left lateral-laryngeal nerve palsy caused by mechanical compression of the nerve due to enlargement of the left atrium in mitral stenosis. So if a patient with mitral stenosis has got a hoarseness of voice, then we have to suspect that there is a left recurrent laryngeal injury or compression because of the left atrial enlargement. This is one of the clinical importance of this left side recurrent laryngeal nerve. What is Semon's law?
It deals with the origin of the muscle.
So Semon's law states that in a progressive lesion of the recurrent laryngeal nerve, the abductors are paralyzed before the adductors. This is what I told you. There is only one abductor muscle, posterior cricothyroid, whereas the four muscles are there for adduction. So the Semon's law states that in a progressive lesion of the recurrent laryngeal nerve, abductors are paralyzed before the adductors. This means that in an incomplete paralysis, the cord will be brought to the midline by adductors, and in complete paralysis, it falls away to the paramedian position. So if you have bilateral partial recurrent laryngeal nerve injury, that is the most dangerous airway obstruction patient can have, because the vocal cord will come and get stuck in the midline because of the powerful action of the adductor. Whereas if you have a total resection or total injury to both recurrent laryngeal nerve, you may still have some opening because the abductors and adductors both are paralyzed here. So it cannot come and meet in the midline. So there will be a small opening because the vocal cords will be in the paramedian position, not in the exact midline position. So partial bilateral recurrent laryngeal nerve injury is the most dangerous airway obstruction because the adductors will come into full adduction in the midline, whereas total bilateral recurrent laryngeal nerve injury will assume what is called the cadaveric position with a small opening between the vocal cords. So patient may still be able to breathe, but he will not be able to phonate, nor he will be able to protect his airway. He will aspirate. So the dangers of total bilateral recurrent laryngeal nerve injury is absence of phonation and risk of aspiration, but patient will be still able to breathe because there is some opening, but it will be partially open. So there will be some resistance to breathing also. But it is the bilateral partial injury which is the most dangerous, which we have to remember. So this question is very commonly asked in the examination. So you must say incomplete paralysis of both the recurrent laryngeal nerve is a dangerous condition. So if the damage is unilateral, then the contralateral cord can partially compensate. So it is very difficult to identify when there is only a unilateral injury. So you have to, that is why we always document the movement of vocal cords before thyroid surgery, because a unilateral palsy cannot be clinically detected. But when you do a nasoendoscopy, you can see one side vocal cord not moving, the other side compensating by overacting onto the other side. So that is the reason why we always have to document the status of the function of the vocal cords before any thyroid surgical procedure. So this is how the, you can see there is a left abductor palsy, only one side, and during phonation they are compensating, whereas during inspiration you can see only one side is moving, this side is not moving. So this is a unilateral ductal palsy. So the opening is made adequate by the overactivity of the normal side, whereas this is the both left abductor and adductor palsy. So you can see the overpulling is there. Again, during inspiration, it is able to compensate. Now, bilateral recurrent laryngeal nerve palsy, where there is a total damage. So you can see there is always a opening in the midline. Unlike here, where they are all totally closed, there is an opening, so patient can still breathe through that. Now, what is the blood supply to the larynx? We go through quickly all that. So blood supply is from external carotid. It gives off superior and inferior thyroid arteries, which give rise to superior and inferior laryngeal arteries. So from the thyroid branches of the external carotid, you get the laryngeal blood supply, and subclavian artery also to some extent supplies the larynx. And the venous drainage is by superior laryngeal vein, middle thyroid vein, producing venous drainage, and the lymphatic drainage is above the vocal cords by the upper deep cervical nodes. So this anatomy knowledge is important to find out the node enlargement in cancer larynx. So above the vocal cord, you will find the enlargement of the deep cervical, upper deep cervical nodes. Whereas if the CA rises from below the vocal cord, you will find the nodes, the lower deep cervical. For vocal folds, there is no lymphatic drainage. So it will be, as I told you earlier, it will be confined to the Broyles ligament alone. It cannot spread outside. And what is cricothyrotomy and why is it safe? When will you do a cricothyrotomy?
Front of neck access when can't intubate, can't ventilate situations.
Fantastic, very good. So it is a crico, the opening made by a small slit or small hole in the avascular cricothyroid membrane. So cricothyroid membrane has no blood vessels, major blood vessels are there. So it is safe to do a opening in that. Can you attempt cricothyrotomy in children?
Yes, sir.
When there is a question like that, that means there is a catch.
It
Do
is
not
difficult
attempt
to palpate the.
cricothyrotomy in children as the membrane is not well developed in them. So there is hardly will be any gap between the thyroid cartilage and cricoid cartilage. That membrane grows, becomes bigger only after the age of 8 years. So up to 8 years of age, children will not have a identifiable cricothyroid membrane. So you will be damaging the cricoid cartilage or thyroid cartilage if you attempt cricothyroidotomy. Okay. So what is shown here?
First step, injection of local anesthetic into um, the testing for
Yes,
the
you can see a series of
bubble.
pictures. You can see a series of pictures. It is not only one picture here. Here they are trying to aspirate. They are not trying to inject. You can see the arrow. So why? What are they aspirating?
Air to
To
confirm
check for
whether
the
it is
air.
infected.
So this is the cricothyroid membrane in an adult. You try to identify it by puncturing it and aspirating air freely. Then what you do is you use the Selding technique. You put in a guide wire and then you make an incision and then you, what is the name of this entire procedure?
Trocar cricothyroid.
Needle cricothyroid.
Called Melker percutaneous cricothyroid. Okay. The technique described by Melker. So it is called Melker percutaneous cricothyrotomy. Now with that we finished the anatomy of the nose and the larynx. Now we go to some non-respiratory functions of the lung. What are the non-respiratory functions of the lung? The part of physiology.
Acid-base
We can
balance.
adjust the metabolic balance in the body.
Acid-base balance.
Acid-base balance. That means elimination of carbon dioxide and maintenance. That is part of the respiratory function. Question is non-respiratory functions.
Renin-angiotensin. It has the
Non-respiratory functions include own defense against spread particulate matter, storage and filtration of blood for the systemic circulation, handling of vasoactive substances in the blood, and formation release of substances used in alveoli or circulation. These are all the non-respiratory functions. Defense mechanism against particulate matter, it acts as a blood storage. Just like liver can give you at least 750 to 1 liter of blood during emergency, lung also can provide blood to the systemic circulation, and it also handles vasoactive. Some of the vasoactive substances in noradrenaline, they are all metabolized in the lung, formation of release of substances in the alveoli. So pulmonary defense mechanism, every day about 10,000 liters of air is inspired into the airways and lungs, bringing into contact approximately 50 to 100 square meters of what may be delicate tissues to the body. And the inspired air contains dust, pollen, fungal spores, ash, etc. They can be hazardous material. Then second function is air conditioning. Temperature and humidity of the ambient air vary widely. The alveoli must be protected from cold and drying out. So the humidification which is done is another non-respiratory function. Nasal turbinates also have a surface area about 150 square centimeters. The inspired air passes through these areas, which is both heated and humidified. Then smell. Because of olfactory receptors present in the posterior nasal cavity, the trachea and alveoli, a person can sniff to attempt to detect potentially hazardous gases or dangerous material. So smell is a very important non-respiratory function. And rapid shallow inspiration brings gases in contact with olfactory sensors without bringing them into the lung. So not all hazardous gases have an odor. For example, carbon monoxide. It doesn't have an odor. That is why you get into carbon monoxide poisoning very easily. Now, filtration of inspired air, that is done by both the heads and vitreae, and also by the immunological defense against biologically active material, and sedimentation, smaller sizes up to 5 microns are gravity wise, which is done by that. They are also trapped by impaction and sedimentation. And how the filtered material is removed is by reflexes in the airway, mainly by bronchoconstriction to prevent deeper penetration and also produce a cough or a sneeze. And the sneeze is done by the nose and cough is via the mouth. And another important thing is the tracheobronchial secretion and mucociliary transport, that is the mucociliary escalator. So the entire respiratory tract from upper airways down to terminal bronchiole is lined by mucus-covered ciliated epithelia, which are an estimated surface of 0.5 square meters. The airway secretions are produced by goblet cells and mucus secreting glands. So there are two types of cells in the mucosal lining. One is the goblet cell, another is the mucus secreting cells. And the mucus comprises of two layers. An outer gel layer which traps the particles which are inspired, and the sole layer that directly covers the ciliated epithelia. So the cilia beat at a frequency of 600 to 900 beats per minute. So the mucus moves progressively faster as it travels from the periphery towards the center. So this picture will tell you about the composition of the mucus. It has got two layers. One is the gel layer, which traps all the particles. The another is the more serious sol layer, which is causing the free movement of the cilia. So these are the goblet cells and mucus producing glands. This is the bronchial wall epithelium. So this picture, if you remember, will be able to understand this easily. So material trapped in the mucus is continuously moved upward toward the pharynx. This movement is greatly increased during coughing. And the mucus that reaches the pharynx is either swallowed, expectorated, or removed by blowing one's nose. It is important to remember that patients who cannot clear their tracheobronchial secretions, like patients who are intubated or patients who do not have an effective cough, continue to produce secretions and get them retained. So if secretions are not removed by the patient by suction or other means, airway obstruction will develop. So this is the importance of this mucociliary escalator. There are dendritic cells and mononuclear phagocytic cells. They inhibit the airways all the way, inhabit the airways all the way from trachea to thermal respiratory units. And immature dendritic cells can phagocytose bacteria and other antigens and ingest them by pinocytosis. After contact with antigens, they mature and migrate to lymphoid tissue to promote tolerance to the antigen and prevent the immune response by releasing anti-inflammatory cytokines. And as the antigen is recognized as a pathogen, activates T lymphocytes and the immune response and inflammation by releasing stimulatory molecules. So this is the main important mechanism how our body system is protected from the contamination or pollution in the airway. So these are all the other functions of the pulmonary circulation, non-respiratory functions of the pulmonary. Respiratory function is mainly for gas exchange, whereas non-respiratory function, the entire cardiac output passes over a very large surface area of the pulmonary capillary bed, allowing lungs to act as a site of blood filtration and storage, as well as for metabolism of vasoactive constituents of the blood. So it acts as a reservoir for left ventricle. So it can give up to 250 to 3 ml, 200 ml blood per square meter of body surface area. And if the left ventricular output can be maintained for a few strokes by drawing blood on the stored pulmonary circulation. And pulmonary circulation acts also as a filter because virtually all mixed venous blood must pass through the pulmonary capillaries. The circulation can act as a filter, protecting the systemic circulation from materials that enter the blood. So the particles that are filtered are small fibrin or blood clots, fat cells, bone marrow, detached cancer cells, gas bubbles, or agglutinated erythrocytes, masses of platelets or leukocytes, and debris from stored blood and intravenous solutions. So this occlusion by these particles could sometimes be disastrous if it occurred in the blood supply to the central nervous system or the heart, causing stroke or myocardial infarction. So before they can reach the systemic circulation, the pulmonary circulation acts as a filter. The mechanism of removal of this trapped material by lytic enzymes in the vascular endothelium of the pulmonary vasculature, also by ingestion by macrophages and penetration to the lymphatic system. So patients on cardiopulmonary bypass do not have the benefit of this pulmonary capillary filtration. That is a very important practical application of this particular function, and blood administered to these patients. That is why we are filtering them artificially before we retransfuse back to the patient. And the fluid exchange and drug absorption, the colloid osmotic pressure of the plasma protein normally exceeds the pulmonary capillary hydrostatic pressure. So this tends to pull the fluid from the alveoli into the pulmonary capillaries and keep the alveolar surface free of liquids other than pulmonary surfactants. And water taken into the lungs is rapidly absorbed into the blood. This protects gas exchange function of the lungs and opposes transudation of fluid from the capillaries to the alveoli. There are two types of alveolar epithelial cells. Type 1 is the most active, pumps sodium and water from the alveolar surface into the interstitium, and aerosol drugs intended for airway only as a bronchodilator is isopropanol, which may rapidly pass into the systemic circulation and produce systemic effect. The lungs are frequently used as the route of administration for all inhaled anesthetic agents. That is also a non-respiratory function. Coming to the metabolic functions of the lung, it can convert or uptake of vasoactive substances and also cause their production, storage, release. And most vasoactive substances which are inactivated, altered, or removed as they pass through the lungs. And the site of metabolic activity is the endothelium of the pulmonary vasculature, which consumes a tremendous surface area in contact with the venous blood. So, what are all the substances which are inactivated? Prostaglandins E1, E2, F2, alpha are nearly completely removed. 50% of endothelin 1 is also removed by a single pass through the lungs. 30% of noradrenaline or norepinephrine in mixed venous blood is removed by the lung. And some substances released into specific vascular beds for local effects are inactivated or removed as they pass through the lungs, preventing from entering the systemic circulation. And those substances that are affected by passing through the lungs, there may be profound differences in the response of a patient receiving injection or infusion of these substances depending upon whether it is administered via an arterial or a venous catheter. And formation release of substances for local use in the lung. Several substances that produce effects in the lung have been shown to be synthesized and released by pulmonary cells. The pulmonary surfactant is one such thing, synthesized in type 2 alveolar epithelial cells, and also partly in cells called Clara cells that are released to the alveolar surface. Histamine, lysosomal enzyme, prostaglandins, leukotrienes, platelet activating factor, neutrophil and eosinophil chemotactic factor, serotonin can be released from the mast cells in the lungs in response to conditions such as pulmonary embolism or anaphylaxis. And chemical mediators involved in hypoxic pulmonary vasoconstriction is produced and acts in the lung. That is the nitric oxide. The bradykinin, histamine, serotonin, heparin, prostaglandin, endoperoxidases are all produced and stored by the lungs cells in the lung and released in general circulation under various circumstances. For example, heparin, histamine will be released during anaphylactic shock, and lung must be able to meet its own cellular energy requirement as well as respond to the injury. So the type 2 alveolar epithelial cells play a major role in response to lung injury. As type 1 epithelial cells are injured, type 2 cells proliferate to re-establish a continuous epithelial surface for gas exchange. Type 2 cells can develop into type 1 cells after injury. So that is how the type 1 cells are replaced by type 2 cells by conversion. The conversion of angiotensin 1 to angiotensin 2 is catalyzed by enzyme called ACE enzyme, that is angiotensin converting enzyme, and it is mainly found in the vascular endothelium of the lungs and the kidney. So these are all the so-called non-respiratory functions of the lung. So this is one of the questions again repeated in the theory examination. So apart from the gas exchange function of maintaining oxygenation and removal of carbon dioxide, there are so many other functions which have to be classified from the point of both lung epithelial activity as well as the pulmonary activity. So the lung non-respiratory function can be classified into the non-respiratory function done by the lining epithelium and the mucosal gland as well as the pulmonary circulation acting as a reservoir as well as metabolism of vasoactive and other drugs. So in that way you can remember all these things. So, do we continue or can we stop here?
Any
Hello?
doubts from the students?
No, sir.
Sir,
No. Okay. So we'll stop here. We'll continue in the next class because it's a huge topic. We'll try to cover some more on the next class. We have to cover diaphragm. We have to cover some of the hypoxic pulmonary vasoconstriction. Is again a question repeatedly asked. And also about the PEEP, importance of PEEP in the lung volumes and capacities. So if we
Yes, sir.
discuss that, I think we'll complete this topic. So we'll have it in the for the next class. Okay.
Yes, sir.
Yes, sir.
Yes. Thank you, sir. Thank you very much, sir.